So there's 4 decision points that you make in triage, okay? The first decision point is the patient dying? That's pretty darn easy, right? This is immediate life-saving interventions that are required. They need an airway, they need emergency medications, or they need that IV for fluid resuscitation right now. If they just need, like if you're in triage and saying, I don't really know what's wrong with this kiddo, they could have malaria, we need to do some labs, but they're not that bad. If you're just thinking you need labs, that doesn't make it life-threatening. You know what life-threatening is. You guys do. These are the conditions that are life-threatening. No airway, they're apneic, they're pulseless, and they have severe respiratory distress, or they're unresponsive. And you see those all day long. So you're very familiar with this decision point. The second decision point is, should the patient wait? Again, we're talking about, we got a 20-minute window for a level 2, and a level 3 in the United States, we're thinking can wait up to 3 hours. You know, like when you have a broken bone, it's still going to be broken 3 hours later, unless we're worried about circulation or, you know, a compression injury of a broken bone. They can wait 3 hours as long as we keep checking their circulation and things like that. So should the patient wait? Go back to your training. Go back to your appearance, this PAT, this pediatric assessment triangle. Just based on your PAT, your pediatric assessment triangle, if any of these things are off, you know they're a level 2. They're going to need to be intervention. You have this experience. You guys know your assessment triangle, and you know your Pew score. So, you know, right here, we know the green, that would be a 3, right? A 3, 4, a 5, a 6. So 5 and 6 would be your level 1, right? 3, 4 would be your level 2 on your Pew score if you were going to kind of make those associations. The fourth decision point is resources. And I don't like the way that the association that wrote these guidelines talk about resources, because it sounds like you're talking money, and we're not talking money. We're talking about how many resources will you need to allocate to take care of this patient. Okay, so am I going to need IV fluids? Am I going to need to send it for an x-ray? Am I going to have to do blood lab draws, urinalysis every day? Those are other things that you're going to need. You know, if you have a patient with a burn, they may not need to be admitted, but they need to come back for dressing changes. They're going to need those resources. That's time. That's the nurses having to do dressing changes. So you have to consider too, how many resources will this patient need? Those significant burns that you see, they'll need a lot of resources. They're going to need admission. They're going to need IV fluid resuscitation. If these are things you consider as well. Complex procedures, simple procedures. So you know your burns are going to need conscious sedation. So they're more higher level. Then the fourth decision point that you include in determining the level of severity of your triage score is your danger zone vital signs, which we just talked about. And that picture had, you know, less than 92. It had the ranges from infants all the way up to 8 years old, which is really primary your age population that you see. So that's the other thing. You know, you're sitting in triage, your mom comes with your patient, and you sit the mom down and tell you know what's going on. These are things that you want in the back of your mind. So what I want to talk about is the way we usually do triage is in a chief complaint manner, subjective, objective. And I love this example because that little child that we had that had the burns all over her face, she had been at home for 2 weeks. She had never been seen for her burn. So an example of a triage that I would write about this patient, right, is, okay, her name is star patient, but her mother told us that she brought the baby in because she had fever, diarrhea, and wasn't eating. Remember? That mom said, you know, the baby's covered with this horrible burn, her head, her shoulders, her arms, her back. And the mom says, I'm here because she's vomiting and diarrhea. She didn't bring her in for the burn. The burn was a week old. So the subjective complaint is this, but that's not the reason we're going to make her an emergency, right? This patient was awake, alert. She was not interactive. We noted first and second degree burns over 30% of her body, including her face, chest, left arm, anterior thigh, back. Wounds are asclerotic and cap refill is delayed in all nail beds. Does that paint a picture to you of the severity of the child without even a vital sign? This was my PAT. This was my pediatric assessment. The patient, if you go back a second, you look at your PAT, the patient was not interactive. She wasn't looking right. She was not even responding to her pain. She had decreased cap refill in her nail beds. And although she didn't have any trouble here, we knew that she was in septic shock. And then her age, 10 months, her O2 sat, 92, her weight, 10 kilograms, temp, she was febrile. Her heart rate was much higher than we would expected for her, and her respiratory rate was higher. It wasn't labored, but it was higher. She was in distress. She was in shock. And then basically for blood pressure, I just put that we could palpate blood pressure at 77. The other thing that's important that you want to collect at triage is, are they taking any medications regularly? Anything. Herbal. Always include any kind of home remedies that they're given by their families. It's so important we know what those are. Allergies, we always have to know that. That's the first two questions we ask, right? And then past medical history. These are a couple of things that, you know, lots of your patients have. History of malaria, history of sickle cell. It's important for us to know that. So I'm recommending, and this is all up to you guys, this is your baby and your show, that you change your original form from having that information that has much information that's really not necessary, just to something like this. That's very simple. And then you circle, it's a level 1, off they go into the ER, level 2. We'll finish getting the vital signs. We'll finish wrapping the patient up to present into the ED, or they're an outpatient. They're gonna get their paperwork, or they're gonna sit in line until the doctor's room calls them in for their assessment and determination whether they're admitted or discharged.